Well, good afternoon. I'm Julie Connolly, and I welcome you to this day of special programs sponsored by the Center for Biomedical Ethics and Humanities, programs that are graciously funded by the Kopacka Family Foundation as part of their 10th anniversary celebration. The foundation was established following the death of Dr. Kopacka V. Rayo by his wife and children. And two of his children, Jay Rayo, Ram Kopacka, are here with us today. And we certainly are happy that you're here and appreciate your support. In 1998, Dr. Rayo suffered a myocardial infarction that was followed by coronary bypass grafting. And that was complicated later by cardiac arrest, hypotension, delirium, and he died after a lengthy journey in the surgical intensive care unit. The experience was not a good one for the family. They wrote, "The experience of the patient's family when things go terribly wrong." Their experience, though, led to a deep commitment of the Kopacka Family Foundation to fostering dialogue among health professionals on the patient-physician relationship, knowing that communication, caring, and interest in the patient can change everyone's experience. I'd like to introduce you to Dr. Rayo, and I'll refer to an article, Santi, meaning peace, that Jaya and Ram had published in the Annals of Internal Medicine about their experience. They describe their father in his retirement as follows, and those of you who frequent the Charlottesville Farmers Market will appreciate this story. He sold Indian vegetables at the local farmers market every weekend. At first glance, he seemed a distinguished older gentleman with a reserved manner and modest attire. The vegetables came from his farm, his refuge from everyday concerns. For the curious who happened by his truck and inquired about the unusual vegetables so carefully displayed, he would provide a quick recipe. Never a money-making enterprise, the farmers market represented another teaching venue for him. He grew up in poverty in rural India and was the first in his village to obtain a doctorate, his in organic chemistry. He was awarded a scholarship from the government of India to study in the United States. The first in his family, the first in his village to pursue higher studies or to travel abroad. He received a PhD in biochemistry from the University of Wisconsin. For 15 years, he was manager of chemical research at Pfizer Cancer Research Institute. He discovered 30 agents subjected to human clinical trials, including mithromycin. A scientist who thoroughly enjoyed the process of research, he continued to work in his lab, write grants, and supervise graduate students well until after he turned 70. From 1969 to 1998, he was a professor in the College of Pharmacy at the University of Florida, where he continued his research and identification of new drugs and was author of 140 peer-reviewed articles as well as 33 patents. He had a passion for teaching and was awarded the Teacher of the Year 3 times by the students of the College of Pharmacy. We are, at the University of Virginia, indebted to the generosity and commitment of this family and their foundation. This is the 11th Medical Center Hour guest and program that they have sponsored, and we're certainly pleased to join them in their 10th anniversary celebration. Thank you. So our guest today is Dr. Robert Klitzman. He is an associate professor of clinical psychiatry at Columbia University. He co-founded and co-directed the Columbia University Center for Bioethics, and he is the director of their new Master's in Science in Bioethics at Columbia. He has extensively studied the areas of ethics, social and psychological issues in medicine and psychiatry, many areas of privacy, disclosure related to genetics, worked with people with HIV infection and looking at issues of discrimination. He's a leader in the field of medical education and doctor-patient communication. Your handout will give you further information about him. He is also an author, and in there are listed a number of books that he has written. We invited him because of his most recent book entitled When Doctors Become Patients, which he can hold up and show. There you go. And the UVA bookstore has some copies for sale after the program if you're interested. We invited him because we wanted to continue our exploration of the doctor-patient relationship by focusing our attention on the issue of physicians who are patients. So, before I turn the program over to him, I want to remind you that we'll have some questions, time for questions, so be thinking about your questions for him at the end of this. And then also an announcement at 5:30 today in this auditorium, he'll lead a panel discussion with 3 UVA physicians who are patients, Walt Davis, Tom Daniel, Joanne Pinkerton. And the emphasis in that will be really looking at what doctors learn from their experience of being patients that might then inform their practice of medicine or might help us inform medical education. So that lecture is at 5:30 and will be followed by a reception when you're on board. So, Dr. Klitzman, welcome.
Well, I want to thank the Kilpatrick Family Foundation and Jaya and Ram for inviting me, and Dr. Connolly for facilitating that, and I want to thank you all for coming. And I think it's really a tremendous thing that the Family Foundation set up, because I think these are really crucial issues that are increasingly important in today's fragmented medical system. And what a wonderful, inspiring model their father is of really the kind of virtues and integrity and sense of importance of human issues in medicine and in healthcare and science more broadly. I think it's really a terrific thing they've done, and I think we all owe them and him a huge debt of gratitude. I thought I would start off just reading the very beginning of my book, When Doctors Become Patients, and then talk about some of the issues. This is the opening. At 8:30 in the morning on September 11th, 2001, from her office on the 105th floor of the World Trade Center, my sister Karen called her best friend. No one ever heard from Karen again. Over the next few weeks, I helped organize a memorial service and a fellowship in her name, signed a death certificate, and packed up all her belongings, sold her apartment, and then my body gave out. For 3 months, I could not sleep. As a result, I had a flu that would not leave me. I could not get out of bed and was no longer interested in reading books, seeing movies, or listening to music. Yet, I was surprised when friends told me they thought I was depressed. No, I'm just sick, I said, resisting the idea. I was a psychiatrist, but suddenly for the first time in my life had physical symptoms of depression and was amazed at the experience, how much it was more bodily than emotional. My body had just given way beneath me. For the first time, I fully appreciated what my patients had to undergo and how hard it is to put the experience of depression into words. It was also hard to accept that I had a mental illness. I felt weak and ashamed and began to appreciate, too, the embarrassment and stigma that my patients had long felt. I went to psychotherapy, memorial events, my temple, and for the first time a Buddhist service, and a psychic who claimed to communicate with Karen, though as a physician I was wary. I sat in Central Park in the middle of the day for the first time in my life, doing nothing at all for hours. I thought my training as a psychiatrist would help, but it was quite the opposite. The experience forced me to cross the border from provider to patient and taught me how much I did not know. I realized that I, as a doctor, would never be the same or look at in the same way at the problems that patients and their families face concerning depression or grief. The difficulties were far more complicated and long-lasting than I had ever imagined. Closure was far more elusive. I wondered, too, how the experience of becoming a patient affected other physicians, and what I learned that I did not know before. And I ended up interviewing 75 other physicians who underwent serious medical problems and tried to see what did they now learn, what had they come to see that they did not know beforehand, and was interested too why they didn't know it. I'm going to talk about that. One of the first patients I interviewed was a woman who said, I used to think of myself as miscompassionate. And it's not till I became a patient with breast cancer that I realized I had no idea what my patients were going through. My eyes were completely open, she said. And there has been a few works, as we know, about doctors who become patients. There was a movie a number of years ago, some of you may have seen, called The Doctor with William Hurt, in which he played a mean, sort of son of a bitch, kind of chauvinistic surgeon. What can I say? Talk about Hollywood stereotype, right? And as a result of his illness, he became a compassionate, loving, wonderful human being. And of course, that's the Hollywood version, right? Sort of from one extreme to the other. But what I found is I interviewed doctors who were good doctors. I mean, I thought they were good doctors, like would have sent patients to them. And yet even they said, I've changed what I now do as a result of the experience. Even I had no idea what it was like. And I think that tells us something. They described how they underwent a journey. Many of them felt that they had what I call post-residency syndrome, where there's something called medical student illness, many of you may know, where in going from a quote, lay person into medical school, into training, suddenly medical students fear that they have every illness they read about. So they'll say, I'm feeling lymph nodes, I must have lymphoma or something. And yet at the other end, there's been very little work from a scholarly point of view of what it's like at the other end to go from being in the profession to then leaving the profession, right? And coming out the other end, so to speak. And really these doctors have double lenses. They feel they had a certain amount of power and they now lost it. And it really forced them to see themselves with the eyes of another, to look at themselves as someone else would see them. And that's a rare thing. There have been a few works of art that have tried to do that. Faulkner's novel, The Sound and the Fury, is the same story told from different perspectives. And Kurosawa's film Rashomon, again, is one story told from a different perspective of different actors. And if you've not seen or read those works, I'd encourage you to do so. Because the problem is that in medicine, we're always taught to see things from just one perspective. The notion that there even is another perspective, another point of view, and what we're doing is something that we're not taught. We're taught we have the answer. And these doctors described how they felt they had a magic white coat on. That there's illness, and here's me, and there's a wall, and that's that, and this is me, and the two won't meet. And yet they had to obviously give up the white coat and see from the outside rather than from the inside. Many described how they completely changed their approach to communication. So, for instance, one surgeon who I describe in the book said, I've been a surgeon for 40 years, and the night before I had to go in for surgery, my surgeon said to me, Jack, there's a 5% chance you may die tomorrow in the OR. And he said, that night I couldn't sleep at all. And it's only till afterwards I realized that the doctor could have said to me, there's a 95% chance that everything will go okay. He said, and I've been practicing for 40 years, and it never occurred to me that those two bits of information, which are statistically the same, right? 5% yes, 95%, have completely different emotional valences for a patient. I never realized that. No one ever taught him that, he even thought of that. And I think that suggests a failure of medical education, that these doctors really describe that giving bad news as an art. And they say they had never really realized that before. And ways to address that, if it's an art, what are the lessons of the art, I think is something we can learn from that I've tried to capture in the book. Similarly, a number of these doctors said, when I left I was hospitalized in the ward, and when I left, the nurse said to me, you were a good patient. You never complained. And they said, it only then occurred to me, is that a good patient? Right? I mean, what is a good patient? Is it someone who doesn't complain? What do we think is a good patient, right? After I wrote this book, people said to me, doctors make bad patients, right? But I think it sort of begs the question, what is a bad patient? What is a good patient? How we think of a bad patient as one who complains, obviously. And should that be the criteria? Maybe you don't want a patient who always complains, but to never complain isn't, I would suggest, good either. Similarly, a lot of issues came out about the role of dignity. So these doctors would describe, I walk down the hall by the radiology suite, 10 times a day for the past 20 years, but then I had to sit there in a flimsy little gown with my butt hanging out, right? And I felt horrible. I just felt so dehumanized. I was admitted to the ward, and this is in New York City, so I'm sure such things don't exist here. But the window was cracked. There was air, cold air coming in. Someone had squeezed a towel in the cracked window. There were no flowers anywhere in the hospital, any clinic, any room that I went into. The food was horrible. It was cold, and this doctor said, a number of doctors said things like this. This is stuff patients complain about all the time. The food's cold, and we don't think about that. That's someone else's job. But then you suddenly realize that all these things mount up and have an effect. Similarly, issues of time. So a number of doctors said things to me like, I went to see my doctor. Do you know he kept me in the waiting room for 40 minutes? He was driven up the wall. So I said, well, have you ever kept a patient waiting? I don't know. I guess so. I never really thought about it before. Well, should we be thinking about it, right? I mean, because, even in outcome studies, and patient satisfaction is often something that is looked at now, but what is the role of loss of dignity in healthcare? It's a soft thing, but I would suggest that it still has a role, and it's something that we as physicians and providers at least need to be aware of, or more aware of than we are. Because it does take a psychic toll. And it's something that these doctors only realized when they were there, right? You can't really measure it. It's not going to show up in a lab test, but it's quite real and important. Similarly, a number of the doctors in communication, my doctor would say, well, your cancer shouldn't come back too soon, or it shouldn't come back for a while, right? And they're left wondering, what is a while? What is too soon, right? And how in language, we speak in euphemisms or code that in a way protects us, right? But also makes it very difficult for a patient to know what that means and how to live one's life. And again, it's something I would argue we need to be more attuned to as physicians. Similar issues came up even getting results. A number of doctors who said, I called to get my results, and it was a Friday afternoon or the end of the day, and the doctor said, well, the doctor's gone, so you have to wait till tomorrow or wait till Monday. And they thought, well, the result is sitting somewhere, right? I mean, why can't I know it now? And so a number of these doctors, so they really make a very proactive effort to communicate results to patients much sooner. As soon as you get the result, you can call Mrs. Jones, tell her it's normal or whatever. I think those are important things. A number of these doctors described they looked at risks and benefits differently. So one doctor, for instance, had a rare kind of lymphoma and said, he read that there was a new treatment out on the West Coast. It had been tried on one patient, and he said he got on an airplane next week to fly out there to be the second patient. So I said, well, would you ever recommend that for one of your patients? He said, no. I said, why not? He said, well, because I'm a physician. I know how to deal with risks and benefits. My patients don't. I wouldn't recommend that for a patient. I just wouldn't. And when pushed, it's almost as if, well, patients couldn't handle that information, right? And yet, of course, a patient may want to be the second patient. Maybe not, but at least the kinds of assumptions we make that this is the amount of risk that a patient will want to take may, of course, be wrong. And it's important to sort of know the degree to which patients can deal with certain kinds of risks, and it varies. Another set of issues that came up consistently were spiritual issues, which surprised me. The doctors would say things like, patients used to ask me, would say, hey, doc, would you pray for me? And I'd say, yeah, well, sure. I kind of poo-poo it. And then they would say, it's not until I became a patient that I realized how important that was, right? That those are issues that patients lying in bed are busy thinking about a lot, all the time perhaps, and that we as physicians pay no heed to. And I think it's something we need to be more aware of, which is not to say we should all be religious or have the same religion, but to be sensitive to the fact that patients are busy thinking about these issues, and to be able to say to a patient, for some people that's important. If you'd like, I could talk to you, or we can have someone talk to you about those issues, etc. At least it opens the door. And this is controversial, obviously, but I think it's something I would argue as a result of this. A number of doctors said, well, I'm, fill in the blank, I'm Jewish or Catholic or Protestant, whatever, and I really don't know about other religions. I don't know what Jews do on Sabbath or when Mass is what Catholics want to do, let alone if I have an Islamic patient. And so I think coming from this, I had the sense that wouldn't it be wonderful if every medical school had at least a lecture on comparative religion. And I think here there is a presence of some information on religion, spirituality, curriculum, but that's the exception at this point in medical education. And again, it's a taboo, and I think historically, at one point, of course, if you go back to the ancient Greeks, medicine, Hippocrates and Hippocratic cult started in ancient Greece at Epidurus and elsewhere. It were really religious sanctuaries where there was the temple and next door was the healing area. It was all sort of combined. And then, of course, in the 19th century, as medicine became more scientific in the West, we very consciously moved it away from these other things, from spirituality. And yet, I would argue perhaps we moved too far. We need to see about ways that through the patient's experience, the patient's experiencing this together, we can think about possible links between them, which is not to give up the science, but I think to sort of see that at times you may want to at least open a little crack in the wall between the two. At the other time, some doctors said, I wish I could believe something. I see it helps my patients, and I just can't bring myself to do that. And it seemed often that was tied to depression, but it seems that I think these are issues that we need to be more aware of the fact that our patients are facing them. Many doctors tried to change what they did with regard to patients' appearance and experiences. One doctor was an endocrinologist, said, I've for the past 20 years, I've told patients that they had to be on a diabetic diet, right? Diabetes, low calories, horrible diet, and they always complain, they don't do it. Well, I decided, I should try being on a diabetic diet. So I said I would try it for 24 hours. They said, I never got past breakfast. And then the doctor said, I preach you have to be careful what you eat, low cholesterol, and then I go out to Burger King. Right? And so what kind of message is that? How this sort of disconnect between sort of what we're telling people and the lives we lead, and how good can the recommendations we make be? How strong can they be if we can't even follow them? And I don't think there's not an immediate answer to that, but I think it's something we need to be aware of. But many of these doctors then said, as a result of more awareness of their own failure as patients to follow what they preached, they would now say things, well, that's good, you have to take your medication 80% of the time. Let's try to work towards a 20%, rather than have you taken all your medication? If not, why not? What's wrong with you? Right? So I think it enables these doctors often to reframe the conversation in a way that I think we can all benefit from. These doctors talked about choosing their own doctors, and many of them were surprised that they found that their colleagues' reputations were not borne out. So they would say, everyone said, go see such and such, go see Dr. X, he's really great at this. You'd go, they said, I'd go, and the guy was like horrible. He didn't listen to me, et cetera, et cetera. He has this great reputation, and it's based on how many papers he publishes, how well he can give a PowerPoint talk, but it's not based on how well he interacts with patients. And so almost across the board, these doctors basically said, and it was quite interesting the way they looked at this. They would say things like, if I look at my medical school class, 95% of us are about the same. Occasionally 2 or 3 guys are just really great, or women, and 1 or 2 maybe weren't as good, but everyone was about the same in technical skill. And therefore, they came to realize that the role of empathy was really important in then separating out sort of the 95% of the rest of us. And I think that that's an important message that we don't pay attention to. Similarly, a lot of these doctors in coping said, I feel I have to be strong. I feel I have to be super doc. I can't cry. And I remember these doctors would get care in their own institution. And they'd say, I go from my office on the 3rd floor to my physician's office on the 5th floor, and I get this diagnosis that something bad, the cancer's coming back, and I'd go back and I thought, I can't cry, I have to be tough. Right? And I think we separate the ways in which we're taught to separate our emotions. At times, it makes it easy to cope during the day, right? Dying patients, you're over here, there. But at times it really gets in the way. And it doesn't mean totally intermesh, But I think we need to be aware that we're setting boundaries, and that at times that may get in the way of our being as good a physician as we can be with our patients. Many have also said, revealed different kinds of magical thinking. Many of these doctors were workaholics, and they said, this is how I deal with my life. I work all the time, so I don't have to deal with my wife or my kids or whatever. I think it gives you lots of professional success. And many of them now question that, of course. And I think we're, in that part of their lives, I'm trying to say, sort of happier as a result, or they're glad in a way that they were forced to question that, and they felt that they were less burned out as a result. And I think that's a lesson for all of us too, because of course burnout and frustration is increasingly a problem among physicians, and of course some physicians turn to substance abuse, other things, but I think the kind of groundedness they got when they were now forced to examine their lives, I think is something that all of us can take home and think about. At the same time, some of them said, as I said, I thought to be super doc, and some docs said, when I got sick, I worked harder and harder. And I didn't want to give up work. I saw more patients, and I felt, if I see more and more patients and help more and more patients, I won't get sick, I won't die. And we think of magical thinking as over there, something primitive tribes do. But of course, I think a lot of the workaholism and the sort of this magical doc keep working hard is a way of dealing with very frightening things that we deal with all the time. And it's easy to dismiss all this, it's all, touchy, feely, but these are very real issues that sort of float through the work we do and that we ignore. I think we ignore them often too much, or at our peril and the peril of our patients. Similarly, I'll just say, a lot of these doctors then had to face questions of should they retire? And they would say, well, am I what I do, or who I am versus what I do? Am I a doctor? Am I a doctor if I'm no longer practicing? And at first I hear this and I think this, this sort of this trivial stuff. But then it kept coming up and up again and again. And they'd say, when I go to the neighborhood block party now, I don't introduce myself as Dr. So-and-so. I'm just Bob, right? Or whatever. And it suggested that there really are big issues in terms of how we define ourselves as physicians, right? And again, how much of that has advantages, but again, may set up barriers. A lot of these doctors also said, for instance, that they became aware for the first time of how patients try to please them. So a number of doctors said, I'd lie in bed and my doctor would come by their door of the hospital and say, everything okay? And I'd say, yeah. And I'd say, wait a second, everything's not okay. Why am I saying everything okay? They'd say, well, if I say, well, actually, I have this and this and this, right? The doctor gets a long face. They say the doctor starts to, fidget. And I became aware that I try to structure and please the doctor. And they said, for the first time, I began to wonder, well, if I'm trying to please my doctor, right, that must mean that my patients are busy trying to please me. And I've never thought about that. Yet that structure is how we can sort of cut off communication, right? So one of these doctors said, I'm a hugger, I like to hug patients. And I realize only now it's a way of saying, goodbye. I'm there, but it's over, I gotta run, right? So it kind of decreases that I feel badly about leaving. I just used to hug, I didn't think about it. And only now do I think about it. So again, there's a lot of informal communication that goes on that in fact communicates the way we feel, and again, can be a barrier. The language, again, lots and lots of examples that I try to describe in the book, just so I don't leave some time for discussion, questions and answers. But they would say, these doctors said, I now realize, doctors, okay, we're going to send you for routine tests. That's a phrase, right? Routine tests. Well, if you're the patient, it's not routine, right? It's routine for us. But if you're the patient and you're wondering if disease X has come back, right? That's a life and death sentence that's potentially coming back. It's hardly routine. And so even phrases like that we use all the time and never think about, in fact, communicate quite a bit and are not part of the patient's experience. It reflects more our point of view, again, than the patient's point of view. Similarly, issues of insurance. These doctors said, I was amazed at just, dealing with insurance as a whole full-time job, and I've never realized that. And I feel like now, some doctors say, I feel like I'm a social worker now. I sort of want to make sure that there's a home health aide, that they have transportation home, all these things that they used to just sort of like be happy not to deal with. I now try to deal with or make sure get addressed in a much more proactive way, because I realize they really are important. And again, I don't mean to burden doctors with all these things, but I think we need to be aware of at least that there's some follow-up, et cetera, that someone is taking care of these issues in a way these doctors before would basically ignore. Another issue came up about seeing errors. So this doctor said, I became aware the nurse wrote down, 104 as a temperature rather than 100.4, gave me the wrong dose of medicine. Of course, if I wasn't a doctor, I wouldn't realize that. And at the same time, these doctors talked about how there were all kinds of implicit norms against criticizing colleagues. So these doctors said, and now because they were patients, what's interesting, they felt freedom to talk about these issues. So they would say things like, the nurses on the ward come up to me and say, can you say something? Mrs. Jones should really be going home. Can you say something to her doc? Right, her doc, Dr. X, is keeping her here. We the nurses says, can you go do something? These docs say, like, well, what am I, am I going to go, how am I going to say something to a colleague? They really felt that there was a taboo against saying, Mrs. Jones, they would say, if I say to the Dr. X, Mrs. Jones, can't she go home? The doc's going to say back to me, like, this isn't your business. This is my patient. You don't know anything about the patient. What are you talking about? Right? That it was very difficult, or when they saw something and they really felt was not right, that there really were very strong taboos against giving each other feedback. And some doctors would say, there used to be the doctor's dining hall for lunch, right? And there would be, all the doctors would get together, and I vaguely remember this as a medical student, right, in the early days, that's how old I am. Now everyone eats lunch, on the run or at their desk or whatever. But doctors just sit at a long table, and there would be interchange. And though that was sort of a ritual almost, in which doctors were able to communicate or give each other curbside consults or say to the pathologist, what do you think of this, or get questions answered. Well, now, because we each deal separately, there's less informal interaction, and that has a cost. And rituals are important. Some of us were talking about this last night at a meeting. I think that kind of informal exchange is something we've lost, and that, again, we pay a price for, and that perhaps we should do more of. Right? Have an occasional lunch or something. Of course, everyone's so busy, but I think these are important issues again. The hierarchy, us and them, a lot of doctors now talk much more about how they became much more aware and sensitive to the fact that there really was an us and them, and quite a gap. And some said, and of course, medical sociologists have written about this, that there's a need for detached concern. Right? You don't want to be too detached, but you don't want to be too concerned. And yet, navigating that for each patient often can be quite difficult, and these doctors have reflected on that. So they would say, I decide, okay, I'm going to be perfectly equal with my patients now. And they'd say, what do you think I should do? And they say, well, I'll let you make the decision. And patients aren't always happy with that, right, being that non-directive. And occasionally they'd say, sometimes I need to say, look, Mrs. Jones, you have to take your medicine, et cetera, et cetera, et cetera. Similarly, things these doctors watched in terms of how they actually had a placebo effect, if you will. But they said, I realized my doctor would put her hand on me and say, it'll be okay. And I felt so much relief. And I never realized that I must have that same effect on my patients, that just our presence can be effective. And yet we sort of ignore placebo effect. It's, quote, not real. We sort of put it over here somewhere. And yet perhaps it is something in our toolbox that we could draw on and rely on, and that can help our patients more if used appropriately. I can go on with some of these issues, but I thought maybe I'd stop there and see if people have questions or comments or reactions, and I'd be happy to talk more if people want.
Raise your hand if you have a question. I'll bring you the microphone, and we'll move on from there. Okay, hang on a minute. Give us your name, please. Thank you.
Hi, I'm Chris Peterson, and this is a frog in my throat speaking. I have a question about whether you've noticed any gender differences when doctors are patients. And where that comes from is that I'm a gynecologist, and I do all my clinical work in a student health setting. So all of my patients are students, many of them are medical students. And an annual GYN exam, or any kind of GYN exam, is not exactly when a person feels most powerful and dignified. It's
Right.
a condition of great vulnerability. So it's instructive both to the patient, having the exam about the vulnerability, and also to the physician who's recognizing that, hey, this is a teaching opportunity as well. I'm wondering if you found differences, since most women have GYN exams and experience that vulnerability in a recurrent way. Did that seem to have an impact?
It's a great question. Everyone heard the question? These doctors often asked, are women more sensitive, empathic than men? And yet many had examples of women who were, a woman surgeon who was, whether it's the way she started out or the way the profession molded her or the fact that she survived the profession, were often, quote, hard-nosed or were tough and not as sort of on the warm and friendly scale. And many of the men were very empathic. So I think even though there is a sort of stereotype out there about differences, that in fact men can be very empathic and women are sometimes less empathic than one would like. What's interesting is on that is that a number of people raise the question, well, can you teach empathy? Right? And it seemed to be what came out again and again was the fact that perhaps you couldn't teach empathy, but there were definitely skills that came out, I should say, that people found were very helpful. So, for instance, and this is a direct answer to your question, but just as a sort of riff on it, in terms of differences in empathy between genders. A number of these doctors said, that, for instance, when they were in the hospital, their doctor, instead of filling out the charts or, typing the chart notes in the nursing station, would come and sit by the edge of the bed, right, and have a few more moments of interaction with me as a patient. They'd say, I now do that with all my patients, regardless of male, female, and they tell their fellows and medical students to do that. Or when a number of these doctors would say things like, when I was a patient, one of my doctors, instead of standing up at the foot of the bed, would pull the chair over and sit down and look at me eye to eye. And I never did that before in my 20 years of practicing. But now I do it, and I tell all my students, men and women, to do it and try to follow up with them. So I think, again, there are skills that we can teach. These doctors tell us that I think cut across gender differences. Similarly, these doctors would say things like they now tell their patients, make sure they try to tell their patients routinely, or say to their patients routinely at the end of every visit, do you have any questions? Right? And also to say, I'm sorry to have kept you waiting. And they often say the tension melts. And they say, I've never done that before. Sometimes I forget and I catch myself, and occasionally I'll go back in the room, and occasionally I just forget. But I try very consciously to always say those things to patients at the end of every session. And it is, doesn't to say, do you have any questions, and especially to say, I'm sorry I've kept you waiting, right, doesn't take much time, but makes patients feel that someone is at least a little more aware of their experience. In fact, they've been sitting there for 45 minutes and they're, just as busy sometimes as we are. So again, I think things like that can help. At the same time, one thing more provocative that came out of this is, and I suggest in the book almost these, a number of these doctors said, I've had to learn to play act empathy. Right? Sometimes I'm busy, et cetera, and I've had to learn how to act empathic. It doesn't come naturally to me, but I realize it's important as a result of having been a patient myself. And so I try to sort of, script myself to do this. And it occurred to me almost that perhaps we should incorporate that in medical education, how to play act empathy. I mean, it's sort of cynical. It sounds like something Dick Cheney might say, right? I shouldn't say that. But it could be seen as being cynical. On the other hand, I think there are times that we need to be empathic and there for the patient, even when we may not feel like it. And I'm reminded there's two schools of acting, right? There's the British school and the American school. And the American school is the method where you should draw on what you feel. And the British school it's just a role. You act a role. And at times, I think, ideally doctoring draws on what we feel, but at times it is a role. And I think that we may need to say that this is part of the role of being the empathic doctor, that we need to act, even if at times we've been up all night and don't feel like it in that way. I'm sorry about the Dick Cheney one.
I'm Ann Hamrick in the School of Nursing, and I've got lots of questions for you about nurses and doctors, but I won't go there right now. The question I want to ask is, you talk about this as if these are life-changing and last forever. Do you think that the experience of illness fundamentally changes the way physicians practice? Or in fact, is that more of a momentary change and then people go back to their old habits? Is there any research on this, or what is your observation?
There's no research on that. It's a very good question. We know from other behavioral interventions and things, whether it's stopping smoking or getting rid of other risky behavior, that there is an often lapse over time. Many of these experiences, I think, to confront mortality in a very direct way is an extraordinarily powerful experience. It really can transform you. And I think that many of these doctors, even if they may perhaps do it a bit less over time, right, that the experience does stay with them in fundamental ways. And I think, redosing, so to speak, or being reminded of it is important. These doctors talked about often having to be reminded. So one doctor said, for instance, that patients would send thank you notes, or a patient would die, the family would say thank you very much for caring. My mother used to throw them out. Now it is I keep them. I keep them in a drawer, top of my desk, and every once in a while I pull out the drawer and look at them. And it reminds me of really what it's all about and what I should be doing. So I think some of these doctors wrestled with that and realized that this is something that could be transient, but they try to hold on to it. It's hard. There's a scene in a Dostoevsky novel, which is based on, I think, The Idiots, which is based on his own experience, which is he was told he was going to be executed. And the character in the novel describes this, he said, at a party, a cocktail party, but it was some sort of salon, in Russia. And the character's telling the story of someone else, and he was told he was going to be executed. He was taken through the streets, and he knew this was the last time he was ever going to see children play, the last time he was going to see a vegetable market, the last time he was going to see a church. If I had to sort of, live, one more day, I'd live completely differently. And he got there to be executed the very last minute. An intervention came to stay the execution, so he was not killed. And so the woman hostess says, well, so did he change? Right? And I said, yes, you read the novel. He didn't. I mean, he didn't. I mean, it was Dostoevsky, so he became a writer as a result of that. That experience actually happened to him. But it's a struggle. And the novel addresses it more complexly, but it's the best description I know of that issue.
Hi, my name is Dave. Right here. I'm a first-year med student. And they say that now we have the most empathy, and from now on it just declines. And I really feel that that's because we're dealing with jaded physicians. And I think for the next 10 years, that's all we're going to get to see. And we'll be the runt. We'll be, you go do this, you go do that. And all we see as people above us are, well, I guess kind of cynic, are jaded physicians. And you talked about how important it is to have communication between nurses and physicians and doctors. But how can you, as a runt, say, I think you're doing it wrong, can you have effective communication between someone you think is just kind of far out there?
It's a great question. There were a couple of papers done around 15 years ago looking at, does medical students see ethical problems in training? Do you know this work? Do people know this work? So Chris Freutner and Dmitry Christakis wrote a couple of papers about how, in fact, medical students often did see things that were ethically troubling. And it's a big problem. What do you do? And I would say, what do you do in any organization? Forget if you're a medical student. What if you're a fellow and you see your supervisor? What if you're working in a lab and see your supervisor? What if you're chair of a department and you see the dean, right, doing something that is questionable or unethical, right? These are major questions that we will all face, and we all do face through our lives. There was a study in Nature published a few years ago by Martinson called "Scientists Behaving Badly," and they asked anonymously, and they found that 20% of the scientists rather said that they had left points off, or data points off, when they didn't think they were right. They sort of fudged their data a little bit, right? So this stuff goes on. And these are questions, and it's a struggle. I would say if this is completely ignoring it, and this is going up to the person saying, what the hell are you doing? Right? I would try to find some way to address it if you feel you can. Either talk to peers, find someone who's sympathetic. Being a whistleblower is problematic, obviously. But there may be ways of saying very gently, I'm just wondering, I see we did this, might that be a possibility as well? And again, I think that in terms of seeing when there are problems like that, I'd say that if there's a way not to just completely ignore it, that might be beneficial. Obviously, it's a case-by-case basis. The larger problem you're talking about though, is that, in terms of medical students starting off empathetic and getting more cynical or more jaded with time, I think can be addressed. I think that, in part of the reason I wrote the book, and I think that the Kopaka Foundation and there are others foundations as well that have tried in little ways along these kinds of lines. It's a huge area that needs work. To try to educate physicians at different stages of their careers, right? Residents, fellows, attendings, etc. And I think to be constantly reminded there is this other side of what we do that's important. I think morally that we should continue to try and to talk to our peers, to talk to not just accept, oh, we're going to get more jaded and that's that, and so we can forget this, but I think the more we can try to address this at different stages, the better. I know in Columbia there was the Arnold Gold Foundation gave money to have, sort of humanism in medicine, monthly lunch for the residents in medicine, for instance, internal medicine, to sort of talk about these kinds of issues. So I think that the more can be discussed, the better. It is uphill, but I don't think it's impossible.
My name is Don Moore. I'm a chaplain here at University of Virginia Hospital, and I was impressed by what you said about learning skills and play acting even when you don't feel like it, because what struck me is that too is a discipline of learning skills, just like I imagine learning other disciplines in medicine are. And it's not something that necessarily is determined by what you're feeling or by, as you say, by feeling empathetic. It's a discipline, a relational discipline that can be learned.
Yes, I think so. I'm sure in the clergy it's a similar thing. I don't actually know how the clergy does it, but I mean there must be a way that it's addressed of course, I'm speaking out of my depth here, but there's all kinds of rituals, or one is every week there's a sermon on these issues to sort of reinforce these kinds of things, if nothing else.
I'm Margaret Mormon, and first want to thank you for a lovely presentation. It's very interesting, very important. My question is, have you, in your research, found any reflections on the experience of being a doctor to doctors?
Yes.
The sort of flip side of this, the issues of, how, I cover that from some experience as a patient,
yes,
and having physicians who assume too much about what I know.
Yes. So there's a whole set of issues around self-doctoring and doctoring, being a doctor of the doctors. So a number of these doctors, a few points. One is those physicians who have a medical problem, which they are familiar with treating or comfortable treating, are much more likely to self-doctor than those who have a condition that they're not used to treating. So if you're a pediatrician and you have cancer, you're not used to dealing with adults with cancer, you're much more likely to cede authority to the physician. On the other hand, if you're an internist, right, an adult internist, and you have a problem that you're used to treating yourself, there's much more self-doctoring. And self-doctoring, there's been some literature on it, but it really is, there are a number of huge issues come up. So some of these doctors would say things to me like, when I went into the hospital for surgery, I brought a little baggie with my own pain meds, because this way I wouldn't have to bother the staff when I get pain meds. Maybe that's good. Maybe we should all do that. I don't know. But I think that says something, right? That he felt he just wouldn't get what he needed from the nursing staff, and so he decided to take responsibility. A number of these doctors said they had been a physician to other doctors. So a few things. So one is there's a lot of where there are these ambiguous roles. So one of these physicians kept referring to the guy who writes my prescriptions. So I spoke to the guy who writes my prescriptions and said I needed this. I said, well, is that your doctor? Well, he's not really my doctor. I write his prescriptions, he writes my prescriptions. So he's the guy who writes my prescriptions. And we can imagine this going on, right? I mean, this is, right? There's also, by the way, doctoring your family. So a number of, and to get back to your earlier question, a number of these doctors talk, particularly for their daughters, to be the daughter of a physician. And so the doctor's either saying, this is what you should take, or this is, you shouldn't do this, et cetera, et cetera. This is sort of male doctors dealing with female daughters. And I didn't put that in the book, but there's a lot of issues around that about what it means to be the child or the spouse of a physician, and the way in which your medical care is either done or not. And that's really not been talked about in the literature. It's a huge area, an important area, I think. But so a number of these doctors would, I treat some doctors, and I'm one of several people they treat. That they're getting treatment from. And I say to them sometimes, well, am I your doctor, or is the guy over there? Or they'll do curbside consults to sort of get, I sort of quasi-doctor them, someone else quasi-doctors them, and those are problems. So there's a lot of ambiguity when it comes to us being sick. Now, you can say in a fractured medical system, and I should say the other thing is, by the way, VIP status, right? So a number of these doctors had very difficult decisions to make about they could be hospitalized in their own institution, and they would be VIPs, and they would have no privacy. And so some of these docs would say, I was on the ward, and my attending came by, as a fellow, said, my attending came by and said, well, I just read through your chart, it looks like you're all ready to go home. And he felt mortified, right, that this attending was going through his chart. So that's a disadvantage. On the other hand, if you're in your own institution, you do get treated as a VIP, but of course that can be both a plus and a minus, right, in terms of, we know about VIP syndrome. On the one hand, the problem is these doctors do have certain resources. They say, I have all the page numbers of all the doctors. I page my doctor, or, right, or, and we laugh. This is the way things work, right? But also having insider status. And yet, still, I should say, these doctors run into huge problems. I could talk more if I wanted to have more of a I thought it was good to have these kinds of issues and more of a discussion. But they would say, I knew I was going to the ER. The doctor said, go to the ER. Well, how do you admit it? Your bed's already there. And I still just sit in the ER for 12 hours. And once I got to the floor, it's not until I called up my buddy, who's also in the same department as my doc, and, so people were busy sort of calling up their friends in the system to sort of help get things done, and sometimes that's the only way things got done. And what does that say about our medical system if you are, quote, merely a patient, right? And the other side, by the way, is the notion I'm just a patient now, right? I mean, what that suggests in terms of a lot of language came out about the hierarchy, doctor, patient. Not only is medicine hierarchical in terms of, attending, resident, intern, medical student, patient, patient's family, right? So, and I think there is a hierarchy there, and very much a sense of power that we really don't look at as much as we should.
My name is Elizabeth Howard. I study nursing and bioethics, and I'm curious as to the effectiveness of doctors sharing their experience as patients with their colleagues. Do you think, or have you found that it's an experience a doctor has to have personally in order for it to make a lasting contribution on their practice?
No, it's a very great question. Two things. I think, first of all, that doctors' experiences of being ill can have a tremendously important impact on other physicians, and does, because for the following reason. Quote, patients complain, right? What these doctors say, being ignored, the indignities, or something that they've heard from patients, but it's not till a physician says, hey, I'm one of you, and I feel this way. I'm one of you, and I know this is something we ignore. That, I think, is particularly powerful, because it's coming from within. So I think that this, I think this does resonate with physicians. At the other side, just to say, there's a lot of material that came out about how physicians ignore other physicians who are ill. Right? So one of these was a fellow who had breast cancer, and she was hospitalized, and when she got back, her name was taken off the list of voicemail. Her patients were all taken away from her. And, people couldn't look her in the eye when she walked down the hall. And they had she had breast cancer, the word was out, I guess it had there's a question it had metastasized, and so she's going to be dead, she's not going to come back, and just reassign her patients, blah, blah, blah. Never talked to her about it. Then she did better than expected, wanted to go back to work, went back to work, and they didn't quite know what to do with her. Similarly, I should say, a lot of what people call peripheralization. If you were ill, somehow you weren't promoted, you were ill, you were better now, but when it came time for promotion, who's going to become the chair or the director, whatever, you were kind of passed over, even though you should have been it, because you were sort of tainted. So how we deal with each other's illness, I think, says something in terms of our sensitivity. And again, I think, we're all human beings, and I think we can draw on that more to be better doctors to ourselves, to our colleagues, and to patients.
One last question.
Preston Reynolds.
Hello, Robert.
How are you?
Wonderful
Long time.
scholars together.
I want to push you a little bit on this veil of silence, because I think as physicians we are so at risk of not caring for ourselves and seeking the care medically, psychologically, in a whole host of ways that we need. And then also not reaching out to our colleagues. So it's always do what I say, don't do what I do. And does your work really lift that veil of silence and allow us to have conversations about doctors becoming ill, giving us license and privilege to in fact acknowledge that it's part of our profession, and then finding different ways to heal and care for one another?
It's a great question, and I think we can do more. I think that in a number of illnesses, we live in a very increasingly confessional society, right? Thanks to the Oprahs and Jerry Springers and Dr. Phil, whatever, right? So increasingly people are now out about their depression, for instance. William Steyer wrote a book about depression. People, celebrities come out about their substance abuse, be it, Whitney Houston, whatever. So in some ways, the sort of 1950s notion of everything's perfect, right? We moved away from that. But that's happening outside of medicine, right? And I think that, that's not to say we should all be completely confessional, but I think that's going on in the culture. I think there is less stigma to a lot of these things, and I think that we should draw on that, and that we should be, open our white coats more, if you will. And that doesn't mean open it all the time, all the way, or be flashers. But I think to unbutton it sometimes, or take it on and off, I think is important.
Please join me in thanking Dr. Klitzman for wonderful.